This is an AI-generated podcast based on a chapter in the book Gastroenterology Clinical Focus by Dr. Emad Qayed. We hope this podcast helps you strengthen your understanding of gastroenterology. Please like, subscribe, and share this channel with colleagues and students who might find it useful.
Welcome to the deep dive. We've got a really substantial chapter in front of us today, focusing on the large intestine pathology, screening, the work.
We'll be covering a lot. Infections like traveler's diarrhea, C. diff, those complex hereditary syndromes, and crucially, the latest on colorectal cancer screening.
Okay, let's dive in. Where better to start than with GI infections? Always a major area. So diagnosis first. It seems like we've had a bit of a revolution here, moving from old school cultures and microscopy to these multiplex PCR panels, the GI panel assays. What's the story there?
It's really about speed and scope. These panels, well, they could look for over 20 different pathogens, bacteria, viruses, parasites all at once. You get results much faster than waiting on cultures.
Faster is good, but what's the downside? Is there a trade-off?
There is. Cost is one factor, sure, but maybe more importantly, it's about clinical interpretation. These tests are incredibly sensitive. They detect DNA. But just because you find DNA doesn't automatically mean it's causing the active infection. Some bugs can just colonize without causing problems.
Oh, right. So you could get a positive result that isn't actually the cause of the diarrhea, which means you can't just order these on everyone.
Precisely. The guidelines are pretty clear. Reserve them for situations where the result will genuinely change how you manage the patient.
Okay, so who qualifies? Who needs this high-tech approach?
Think significant symptoms. Diarrhea that's lasted over a wink, or if there's blood or mucus involved. Also, patients who are moderately to severely ill, maybe fever, low blood pressure, and definitely high-risk groups.
High-risk,
like patients with HIV and low CD4 counts, say under 200, or people with IBD or transplant recipients. Their immune systems are compromised, so knowing the specific pathogen is critical.
Got it. And even with these big panels, C. diff testing is usually separate.
Yeah, Clostridioides difficile, or CDI. Because it's such a common hospital-acquired infection and needs specific rapid management, it generally has its own testing pathway, often PCR or EIA tests for the toxins. It needs a fast track.
Okay, makes sense. Let's talk specific bugs then. Starting with a classic, Vibrio cholerae. How does that cause such dramatic diarrhea?
Cholerae is all about the toxin. The cholera toxin has this active part, subunit A, that gets inside the intestinal cells. Once inside, it basically flips the switch. It activates adenylate cyclase permanently.
Permanently. What does that do?
It cranks up intracellular cyclic AMP, or TMP, levels way, way high. And that high CMP tells the cells to just pump out chloride ions, sodium follows, and water rushes out into the gut lumen to balance things. Massive fluid loss.
Hence the rice water stool. So is everyone equally susceptible?
Not quite. You actually need a pretty big dose of the bacteria, usually like 10 to the 8th organisms or more. But, and this is key clinically, the bacteria hate stomach acid.
So people with low stomach acid are more vulnerable, like those on PPIs.
Exactly. Chronic proton pump inhibitor use reduces stomach acid, sometimes significantly. This lowers that natural defense, meaning a much smaller number of bacteria can actually cause infection. Big risk factor.
Okay, then there's the other Vibrio vulnificus. Our sources flag this one as really dangerous, the top cause of seafood-related deaths in the U.S.
Yeah, vulnificus is much rarer, but far more lethal. It's mostly linked to eating raw shellfish, especially oysters, but also wound infections from contaminated seawater. The group at highest risk by far is patients with cirrhosis.
Why cirrhosis specifically?
Their immune system, particularly how they handle encapsulated bacteria, is impaired. So if they ingest vulnificus, they're incredibly prone to developing rapid, overwhelming sepsis.
What kind of illness does it cause? Is it always sepsis?
It presents in a few ways. There's the wound infection, which itself has maybe a 15% fatality rate. There's gastroenteritis, usually milder. But the one we really fear is the primary septicemia after ingestion, especially in those cirrhotic patients. The fatality rate there can be around 50%. It's terrifyingly fast.
50%.
Huh.
Wow. Okay, shifting gears to E. coli. It's not just one bug, right? There's a whole spectrum. Let's start with E-tech.
Right. E-tech, enterotoxigenic E. coli. This is your classic traveler's diarrhea culprit. It works by releasing toxins, but it doesn't invade the gut lining. It has two main toxins, heat labile, or LT, and heat stable, ST.
How do those work?
LT is very similar to cholera toxin, actually. It ramps up KMP. ST works differently. It activates guanylate cyclase, increasing CGMP. The end result of both is fluid secretion, leading to that watery diarrhea travelers know too well. Usually self-limited, though.
Okay, so E-tech is mostly annoying. But then you have EHEX, or STEC, like O157.H7. That one sounds much more serious.
It is. EHEC stands for enterohemorrhagic E. coli, and STEC means Shiga toxin-producing E. coli. These guys are different. They do invade, and they produce potent toxins, Shiga-like toxins.
And what do those Shiga-like toxins do?
They target the lining of small blood vessels, the endothelium, especially in the kidneys and gut. They damage these cells, leading to tiny blood clots forming. This process is what causes hemolytic uremic syndrome, HUS.
HUS, that's the triad, right? Anemia, low platelets, kidney failure.
Exactly. Microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. A devastating complication, particularly in young children.
So given this specific mechanism, the toxin-damaging blood vessels, what's the absolute crucial point about treatment? This seems really important.
It is, and it's counterintuitive for an infection. You do not treat EHEC-STEC with antibiotics.
No antibiotics. Why not?
Because giving antibiotics, especially certain types, actually stresses the bacteria and causes them to release more Shiga-like toxin. You can literally increase the risk of the patient developing HUS by trying to treat the infection with antibiotics.
Wow. Okay. So treatment is just supportive care. Fluids.
Purely supportive. Fluids, monitoring kidney function, managing electrolytes, no antibiotics. It's a critical point to remember.
Definitely. Okay. Quickly comparing Shigella and Salmonella gastroenteritis then. Different treatment approaches there too.
Yes, based on how they behave. Shigella is incredibly infectious. You only need maybe 100 bacteria to get sick. And it directly invades and destroys the colonic lining, causing dysentery, bloody, mucousy stools.
So because it's so easily spread and invasive,
antibiotics are recommended for all confirmed Shigella cases. It shortens the illness, reduces severity, and importantly, limits shedding and spreading it to others. And just as important, no antidiarrheals like loperamide. You don't want to trap that invasive bug in the colon.
makes sense. And Salmonella, the typical non-typhoidal kind.
For standard Salmonella gastroenteritis, it's usually self-limiting. So antibiotics are generally not recommended. They don't really shorten the illness duration, and they can actually prolong the time the person carries and sheds the bacteria in their stool, which isn't helpful.
So when would you use antibiotics for Salmonella?
Only in specific cases. Very young infants, the elderly, people who are immunocompromised, or if the disease is unusually severe or looks like it's becoming systemic. Otherwise, supportive care is the way to go.
All right. Moving on to parasites. Entamoeba histolytica, what's the main concern there?
E. histolytica is interesting because it can range from just hanging out in the colon asymptomatically cyst carriage to causing invasive colitis with bloody diarrhea, sometimes those characteristic flask-shaped ulcers you see on scope. But the big worry is extraintestinal spread.
Like the liver abscess.
Exactly. The amoebic liver abscess is the classic complication. The amoebas invade through the colon wall, get into the portal circulation, and set up shop in the liver.
How do you know for sure if it's invasive disease versus just carriage? Is there a specific diagnostic clue?
There is. If you look at the trophozoites, the active moving form of the amoeba under the microscope, and you see ingested red blood cells inside them, that's called erythrophagocytosis. Seeing that is considered diagnostic for invasive E. histolytica disease.
And treatment needs two steps, right? Why both a systemic and a luminal agent?
Because you have to treat both forms of the parasite. For the active invasion, the colitis or the liver abscess, you need a drug that gets into the tissues, like metronidazole or tinidazole, that kills the invasive trophozoites.
But that doesn't get rid of the cysts in the gut.
Correct. The cysts are tough, they stay in the colon lumen, and they're what get passed in stool and spread the infection. So after you've treated the invasive disease with metronidazole, you must follow up with a luminal agent, something like paramomycin, to eradicate those remaining cysts. Otherwise, the patient could relapse or continue to spread it.
Got it. Dual therapy is key. Okay, let's tackle the big one in hospital settings. Clostridioides difficile. CDI.
All right, new name Clostridioides, but same old problem. Still, the leading cause of hospital-acquired diarrhea. The risk factors are pretty well established.
Remind us of the big ones.
Age over 65 is a major one. Prolonged hospital stays, obviously. Exposure to certain antibiotics is huge. Fluoroquinolones, cephalosporins, clindamycin are classic culprits, and underlying conditions like IBD can increase risk. There's also some association with PPI use, though that's debated a bit.
And the damage is caused by toxins, A and B.
Yes, toxin A, an enterotoxin, and toxin B, a potent cytotoxin. Toxin B is generally considered the more virulent one. And then there's the hypervirulent strain everyone worries about.
The NAP1BI027 strain. What makes it so bad?
It's got a few tricks. It seems to produce much higher levels of toxins A and B, due to a genetic mutation, plus it produces a third toxin called binary toxin. This combination just leads to more severe disease, lower cure rates with older treatments, and higher rates of recurrence. A nasty bug.
Testing for CDI can be confusing. There are different strategies. What's the guiding principle for when to test?
The most important thing is, only test patients who have new unexplained diarrhea. The standard definition is usually 3 or more unformed stools in a 24-hour period.
And crucially,
do not do repeat testing if someone was recently positive, like within 7 days. And never test just to see if they're cured after treatment. People can remain colonized. Testing for cure is not recommended and just leads to confusion.
what about the tests themselves, PCR versus the toxin assays?
PCR is very sensitive and specific for the C. diff organism's genes. But because it's so sensitive, it might pick up colonization, not just active infection. So many hospitals use a 2-step algorithm.
How does that work?
They might screen with a GDH test. GDH is an enzyme produced by C. diff, so it's a sensitive marker for the organism's presence. If the GDH is positive, they then follow up with a specific toxin EIA test to confirm that toxin is actually being produced, indicating active disease. It tries to balance sensitivity with specificity for active infection.
Okay. Now, management. Big changes in the 2021 guidelines moving away from metronidazole.
Huge shift. The primary recommended agents now for an initial episode, whether it's non-severe or severe, are either oral vancomycin or fetaxamycin.
Why the downgrade for metronidazole?
It really comes down to drug levels in the colon. Vancomycin given orally stays in the gut and achieves very high concentrations right where the infection is. Same for fetaxamycin. Metronidazole, even given IV, gets absorbed systemically and doesn't reach high enough levels in the colonic lumen to be reliably effective, especially in more severe cases. The data just showed Vanac and fetaxamycin are superior.
Fetaxamycin is newer and more expensive. What's its advantage over vancomycin?
The initial cure rates are pretty similar between the two. The big advantage for fetaxamycin is a significantly lower rate of recurrence, particularly in patients who don't have that hypervirulent NAP1 strain. So while it costs more upfront, it might save costs down the line by preventing costly recurrences.
And for the really sick patients, severe or fulminant CDI shock, ileus, sky-high white count.
If they meet criteria for severe fulminant disease, think hypotension, shock, ileus, or maybe a white blood cell count over 15,000, or creatinine rising more than 1.5 times baseline, then you need combination therapy. That's high-dose oral vancomycin plus intravenous metronidazole.
Why add IV metronidazole back in then?
The thinking is that in very severe, potentially systemic illness, the IV metronidazole might offer some benefit beyond the luminal vancomycin. And if the patient has an ileus, meaning the gut isn't moving, so the oral Vanac can't get down there, you have to give vancomycin via a retention enema as well. Plus, you absolutely need an urgent surgical consult because total colectomy might be life-saving if they're not responding or perforate.
Recurrence is such a headache with CDI. Often it's the same strain just coming back, right?
Yes, usually it's a relapse from persistent spores rather than a completely new infection. Managing the second, third, or subsequent recurrence gets tricky.
What are the options after the first recurrence?
If they got standard vancomycin initially, for the first recurrence you could use fetaxamycin. For a second recurrence, options include a long vancomycin taper and pulse regimen, slowly weaning the dose. Or you might do a standard course of vancomycin, followed by a rifaximin chaser. Rifaximin is thought to help suppress spore germination.
This leads us naturally to fecal microbiota transplantation, FMT, still the heavy hitter for multiple recurrences.
Absolutely. FMT has remarkable efficacy, around 90–92% resolution rates for patients with multiple recurrent or refractory CDI. It works by fundamentally restoring a healthy, diverse gut microbiome that can resist C. diff colonization and toxin production.
And now there are FDA-approved versions. That's new.
That's a major leap forward. We now have 2 FDA-approved, commercially prepared fecal microbiota products specifically indicated for the prevention of CDI recurrence after antibiotic treatment. There's Rebuoti, which is given rectally, and VOWST, which comes as oral capsules.
So this takes FMT from a kind of specialized last resort procedure to potentially a more standardized preventative therapy.
Exactly. It offers a standardized, rigorously screened product that clinicians can prescribe to high-risk patients after they finish their CDI antibiotics, aiming to prevent that next recurrence before it happens. It's a really exciting development in managing this difficult infection.
Okay, let's shift gears from acute infections to chronic conditions. Starting with chronic diarrhea, that's diarrhea lasting more than 4 weeks. How do you even begin to approach that? The list of causes seems endless.
It is broad, but you can narrow it down systematically. The first step is often trying to categorize the type of diarrhea. Is it osmotic, secretory, inflammatory, fatty? Getting a good history is key, but stool studies help classify it.
You mentioned osmotic versus secretory. How do you tell those apart reliably?
The main tool is the stool osmotic gap. It helps differentiate if the diarrhea is caused by unabsorbed solutes pulling water into the gut, or if the gut itself is actively secreting fluid.
Okay, walk us through calculating that gap.
You measure the sodium and potassium concentrations in a spot stool water sample. The formula is basically 290, which approximates normal plasma osmolality, minus 2 times the sum of stool sodium plus stool potassium.
And what does the result tell you?
If that calculated gap is high, say greater than 100 millOhms/K, it points strongly towards an osmotic diarrhea. Think things like lactose intolerance, magnesium-containing laxative abuse, or ingestion of poorly absorbed sugars like sorbitol. These unabsorbed things are osmotically active, holding water in the bowel.
And if the gap is low?
A low gap, typically less than 50, suggests a secretory process. The electrolyte concentration accounts for most of the osmolality, meaning the gut is actively pumping out electrolytes and water. Causes here include things like bile acid malabsorption, certain hormone-secreting tumors like VPOMAs or carcinoid syndrome, or sometimes infection still. A key feature is that secretory diarrhea often persists even when the patient fasts.
Okay, that helps narrow it down. What about telling inflammatory causes like IBD apart from functional ones like IBS?
That's where non-invasive fecal biomarkers are incredibly useful. Fecal calprotectin or fecal lactoferrin.
How do they work?
These are proteins released by neutrophils, a type of white blood cell. If there's inflammation in the gut wall, neutrophils flock there, and these proteins leak into the stool. So high levels strongly suggest an inflammatory process is happening, like IBD or microscopic colitis.
And low levels?
Low levels make significant inflammation much less likely, pushing you towards considering a functional diagnosis like irritable bowel syndrome. They're great for ruling out inflammation non-invasively.
So if someone has chronic watery diarrhea, and maybe the calprotectin is low, but it's just not getting better, what's the essential next step, even if things look okay initially?
If that watery diarrhea is refractory, you absolutely must proceed to colonoscopy with random biopsies, even if the colonic mucosa looks completely normal to the eye.
Why the biopsies if it looks normal?
Because you're hunting for microscopic colitis. This condition causes chronic watery diarrhea, but, by definition, has minimal or no visible endoscopic abnormalities. The diagnosis relies entirely on histology, showing inflammation in those biopsies, both from the right and left side of the colon. Skipping biopsies means missing the diagnosis.
Crucial point.
Yeah.
Okay, flipping to the other end of the spectrum, chronic constipation. How do we classify that? It's not all the same, is it?
Not at all. Broadly, we think about 3 main categories. First, normal transit constipation. This is common, often linked to diet or lifestyle, maybe perceived constipation rather than true delay. Second, slow transit constipation here. The colon genuinely moves slowly, leading to infrequent stools and often laxative dependence.
And the third type?
That's functional defecatory disorders, often called pelvic floor dyssynergia or outlet obstruction. Here, the transit through the colon might be normal, but there's a problem with the coordination of the pelvic floor muscles and sphincters during the act of defecation. They might paradoxically contract instead of relax.
How do you figure out if it's slow transit versus that outlet problem, dyssynergia?
It starts with a good digital rectal exam, assessing muscle function during simulated defecation. But specialized testing is often needed. A SITS marker study is classic.
How does the SITS marker test work?
The patient swallows a capsule containing radiopaque markers. X-rays are taken, usually around day 5. If the markers are scattered throughout the colon, that suggests global slow transit. But if most or all of the markers are piled up in the rectum or rectosigmoid, that strongly points towards a functional defecatory disorder, an outlet issue.
Any other tests for outlet dysfunction?
Yes. Anorectal manometry can assess pressures and relaxation during simulated defecation. And the balloon expulsion test is a simple screening tool the patient tries to expel a water-filled balloon from the rectum. If it takes them longer than a minute, that's abnormal and suggests a defecatory disorder.
So if you diagnose dyssynergic defecation, what's the primary treatment? It's not just more laxatives, right?
Definitely not. Laxatives won't fix the coordination problem. The recommended first-line treatment for dyssynergic defecation is biofeedback therapy.
How does biofeedback help?
It's essentially physical therapy for the pelvic floor. Using sensors and visual or auditory feedback, patients learn how to properly relax their pelvic floor muscles and external sphincter while generating effective abdominal pressure to evacuate. It retrains that neuromuscular coordination. Highly effective for the right patient.
Okay, but for the patients with confirmed slow transit constipation, what are the go-to medications these days beyond basic fiber and osmotic laxatives?
We have several FDA-approved options, mainly the secretagogues. There's lubiprostone, which activates chloride channels. Then linaclotide and plecanatide, which are guanylate cyclase C agonists.
And how do those work?
All three essentially increase fluid secretion into the intestinal lumen. This softens the stool and increases transit speed. We also have prucalopride.
Prucalopride, what's its mechanism?
It's different. It's a selective serotonin 5-HT4 receptor agonist. Stimulating these receptors promotes colonic motility, specifically triggering what are called high-amplitude propagated contractions, the strong muscular waves that propel stool forward, kind of like a pro-motility agent.
Got it. What about the specific problem of opioid-induced constipation, OIC? That can be really tough to treat.
It can be very refractory to standard laxatives because opioids directly slow gut motility via mu receptors in the gut wall. So while you start with traditional laxatives, if those fail, you move to targeted therapies.
Back the PMOR.
Exactly. Peripherally acting mu-opioid receptor antagonists, drugs like naloxegol or naldimadine, the key is peripherally acting. They block the opioid receptors in the gut, relieving the constipation, but they don't cross the blood-brain barrier, so they don't interfere with the opioid's pain relief effect in the brain. The secretagogues like lubiprostone or linaclotide can also be used for OIC if PMORs aren't suitable or effective.
Okay, shifting now to irritable bowel syndrome, IBS. Still diagnosed primarily by symptoms using the Rome criteria.
Yes, the Roma-free criteria are the standard. The core requirement is recurrent abdominal pain on average, at least 1 day per week over the last 3 months, and that pain needs to be associated with 2 or more of the following. It's related to defecation, gets better or worse, it's linked to a change in stool frequency, or it's linked to a change in stool form or appearance.
And we use the Bristol stool form scale to classify that stool form, right? Helping subtype IBS into diarrhea predominant IBSD, constipation predominant IBSC, or mixed IBSM.
Correct. The Bristol scale gives us a common language to describe stool consistency, which is crucial for diagnosis and tracking treatment response.
Now, our sources mention a couple of interesting conditions that can mimic IBS or sometimes coexist with it. What should clinicians be aware of? Let's start with mast cell activation syndrome, MCS.
MCS is definitely something to keep on the radar, especially if the IBS symptoms are accompanied by other seemingly unrelated things like flushing, hives, itching, or even allergy-like reactions. It involves mast cells inappropriately releasing inflammatory mediators.
And it often travels with other conditions.
Yes, there seems to be a significant overlap between MCS, postural orthostatic tachycardia syndrome, POTS, and hypermobile Ehlers-Danlos syndrome, HEDS. So if you have a patient with that constellation, IBS symptoms plus POT-HEDS features, MCS, should be considered. Diagnosis often involves testing for mast cell mediators like tryptase in blood or urine metabolites.
Fascinating. And the other mimic mentioned is alpha-gal syndrome, the meat allergy from a tick bite.
Right, this one is quite unique. It's an IgE-mediated allergic reaction to a carbohydrate called galactose alpha-1,3 galactose, or alpha-gal for short. This carb is found in meat from mammals like cows, pigs, and lamb, but not fish or poultry.
And it's linked to tick bites.
Yes, specifically the Lone Star tick seems to sensitize people. The really tricky part clinically is that the reaction is often delayed. Symptoms like abdominal pain, diarrhea, nausea, sometimes even hives or anaphylaxis typically don't start until 3 to 6 hours after eating mammalian meat. That delay makes it really hard for patients and doctors to connect the symptoms to the food trigger.
So if someone has weird, delayed GI upset after eating red meat, especially if they live in tick-prone areas,
you should definitely consider testing for alpha-gal IgE antibodies. Management is strict avoidance of mammalian meat products.
Okay, back to standard IBS treatment. For IBSD, diarrhea predominant, what are some key therapeutic options?
Rifaximin is a big one. It's a minimally absorbed antibiotic that seems to modulate the gut microbiota. It's FDA approved for IBSD, given as a 2-week course, and importantly, studies show it can be effective upon retreatment if symptoms recur.
Any other key drugs for IBSD?
Aloxaline is another option. It's a mixed opioid receptor modulator. It acts locally in the gut as both a opioid receptor agonist and a delta opioid receptor antagonist. The net effect is reduced motility and potentially reduced visceral hypersensitivity.
But aloxaline comes with a very specific serious warning, doesn't it?
It absolutely does.
Yeah.
This is a critical safety point. Aloxaline is contraindicated in patients who do not have a gallbladder, i.e. history of cholecystectomy.
Why? What's the risk?
There's a risk of causing spasm of the sphincter of Oddi, which can lead to severe acute pancreatitis. The risk seems significantly higher in patients without a gallbladder, so you must confirm the patient still has their gallbladder before prescribing aloxitoline. Very important safety check.
Good to know. What about dietary approaches for IBS in general?
The best evidence is for a trial of the low FODMAP diet. FODMAP stands for fermentable oligomonosaccharides and polyols. These are short-chain carbohydrates found in many common foods that are poorly absorbed in the small intestine and then rapidly fermented by bacteria in the colon.
And that fermentation causes symptoms?
Yes, the fermentation produces gas, leading to bloating, distension, and pain. And the osmotic effect can draw water in, causing diarrhea in some. So a structured trial, usually 4 or 6 weeks of restricting high FODMAP, often guided by a dietitian, can lead to significant symptom improvement for many IBS patients.
What about gluten? Is avoiding gluten generally recommended for IBS?
Not universally, no. While some people with IBS may also have non-celiac gluten sensitivity, the evidence doesn't support recommending a gluten-free diet for all IBS patients. The low FODMAP diet is a broader approach with stronger evidence for general IBS symptom relief. Gluten restriction is usually reserved for those who don't respond to FODMAPs or have specific suspicion for gluten sensitivity.
Okay. Let's move into the non-IBD colitis. We already touched on microscopic colitis, MEC. Remind us of the key features again.
Right, MC means chronic watery diarrhea, a normal or near normal colonoscopy appearance, but inflammation seen only under the microscope. 2 main subtypes, lymphocytic colitis, LC, and collagenous colitis, AC.
And how are they differentiated histologically?
LC is defined by an increased number of lymphocytes within the surface epithelium, usually more than 20 intraepithelial lymphocytes, IELs, per 100 epithelial cells. CC is characterized by a thickened band of collagen just beneath the surface epithelium, typically measuring more than 10 micrometers thick.
Treatment-wise, what's the go-to drug and what surprisingly doesn't work?
The first-line treatment with the best evidence is budesonide, specifically the formulation designed for release in the colon. It's very effective for inducing remission, often over 80%. The surprise was that mesalamine, 5-ASA, which we use in IBD, was found in RCTs to be no better than placebo for MC. So budesonide is the standard.
But there's a catch with budesonide, right?
Yes. The big challenge is relapse. When you stop the budesonide, relapse rates are very high, somewhere between 60% and 80%. So many patients end up needing long-term, low-dose maintenance therapy or alternative strategies.
Okay. Next up, a newer entity. Immune checkpoint inhibitor-induced colitis, or ICI colitis. This is related to cancer treatments.
Exactly. Immune checkpoint inhibitors, drugs like empimumab, anti-CTLA-4, or nivolumab, anti-PD-1, are revolutionizing cancer therapy by unleashing the patient's own immune system against the tumor. But sometimes that revved-up immune system also attacks healthy tissues, and the colon is a frequent target.
Causing colitis, how's it managed?
Management depends on the severity, usually graded 1 through 4. Mild grade 1 diarrhea might be managed symptomatically, maybe holding the ICI drug temporarily. But for moderate to severe grade 2 or higher colitis, you need to stop the ICI therapy immediately and start systemic corticosteroids, usually prednisone.
And if steroids don't work?
If the colitis is steroid refractory, then you escalate to biologic agents that target immune pathways. The most commonly used are infliximab, an anti-TNF drug, or vedolizumab, an anti-integrin drug that's more gut-specific. Prompt recognition and treatment are key to prevent severe complications like perforation.
All right. How about ischemic colitis? What causes that?
Ischemic colitis happens when blood flow to a segment of the colon is temporarily or permanently reduced below what's needed, causing tissue injury. It can be due to a blockage, occlusive, like a clot, or more commonly a low-flow state, non-occlusive, often seen in critically ill patients or after major surgery or dehydration.
Does where it occurs in the colon matter?
Yes, the distribution gives clues. It often affects watershed areas, like the splenic flexure, where blood supply is more tenuous. Isolated right-sided ischemic colitis is less common, but often associated with more severe underlying mesenteric vascular disease and tends to have a worse prognosis. One classic feature is rectal sparing. The rectum usually has excellent collateral blood flow, so it's often unaffected.
How is it diagnosed? Any classic signs on colonoscopy or histology?
On colonoscopy, you might see segmental inflammation, maybe edema, hemorrhage, or ulcerations. A characteristic finding sometimes described is the single stripe sign, a long linear ulcer running along the fold of the colon. Histologically, the pathognomonic finding, if seen, is ghost cells. These are remnants of the colonic crypts where the cell outlines are preserved, but the nuclei and cytoplasm are gone, indicating acute ischemic necrosis.
Okay, 2 more quick ones in this section. Acute diverticulitis. What's the big change in thinking about antibiotics?
The major shift is that for mild, uncomplicated acute diverticulitis in otherwise healthy patients, antibiotics are often not necessary. Several large studies have shown that treating select, low-risk patients with supportive care alone, like bowel rest, fluids, pain control, results in similar outcomes compared to routine antibiotics.
So antibiotics are now used more selectively.
Yes. They're generally reserved for patients with complicated diverticulitis, like abscess or perforation. Those who are immunocompromised have significant comorbidities or show signs of more severe inflammation or sepsis, high fever, significant leukocytosis.
And what about the advice regarding nuts and seeds? Still off limits?
Nope, that's been thoroughly debunked. Large studies have shown no association between eating nuts, seeds, corn, or popcorn and the risk of developing diverticulitis or its complications. Patients don't need to avoid these foods.
And the essential follow-up after an episode?
Always recommend a follow-up colonoscopy, usually 6 to 8 weeks after the acute episode resolves. The main reason is to rule out an underlying colorectal cancer that might have been mimicking or contributing to the diverticulitis presentation. Very important safety net.
Lastly, Ogilvie syndrome. That's the pseudo-obstruction, right?
Yes, acute colonic pseudoobstruction, or Ogilvie syndrome. It's characterized by massive dilation of the colon, especially the cecum and right colon, but without any actual mechanical blockage.
What causes it if there's no blockage?
It's thought to be due to an imbalance in the autonomic nervous system controlling the colon, basically. Too much inhibitory sympathetic activity or too little stimulatory parasympathetic activity. This often happens in the setting of recent surgery, severe illness, trauma, or certain medications.
How is it treated?
First, you rule out mechanical obstruction, usually with imaging like CT. Then, conservative management, bowel rest, NG tube, managing underlying conditions. If the dilation is severe, cecum 10-12 centimeters, or fails to improve, the specific pharmacologic treatment is intravenous neostigmin.
Neostigmin? What does that do?
It's an acetylcholinesterase inhibitor. It increases acetylcholine levels, boosting parasympathetic activity and stimulating colonic contractions. It's remarkably effective, often causing rapid decompression.
Any risks with neostigmine?
Yes, because it ramps up parasympathetic tone everywhere, the main side effect is bradycardia, slow heart rate, which can be severe. So patients must be on continuous cardiac monitoring during and after administration, and you need to have atropine readily available at the bedside to counteract severe bradycardia if it occurs.
All right, let's move into arguably the most critical area for GI practice, polyps and cancer screening. First, just classifying polyps based on their risk. Adenomas are the main ones we worry about.
Adenomatous polyps, which include tubular, villus, and tubulovillus TBA types, are definitely the classic precursors to most colorectal cancers. We categorize them further based on risk features.
What makes an adenoma advanced?
An adenoma is considered advanced if it meets any of these criteria. It's large, 10 millimeters or bigger. It has significant villus components in its histology, villus and TVA, or it shows high-grade dysplasia under the microscope. Finding an advanced adenoma automatically puts the patient in a higher risk category and dictates shorter surveillance intervals.
But there's another important pathway now, the serrated pathway, especially sessile serrated lesions.
Absolutely. The serrated pathway has gained huge attention. While traditional hyperplastic polyps, HEPs, are usually small, found in the distal colon and generally considered benign, sessile serrated lesions, SSLs, sometimes called sessile serrated adenomas, SSAs, are different.
How are SSLs different?
They tend to occur more in the proximal right colon, are often flat, pale, and covered with a mucus cap, making them notoriously difficult to see during colonoscopy. Histologically, they have a distinct sawtooth appearance at the base of the crypts. And importantly, they have significant malignant potential. They are the precursor lesions for cancers arising through the CMP pathway CpG island methylator phenotype.
So missing these SSLs is a major problem.
It's a huge problem. Because they're subtle and proximal, they are thought to be a major contributor to post-colonoscopy colorectal cancers or interval cancers, especially in the right colon. Recognizing and completely removing SSLs is critical for effective cancer prevention.
And this led to a new quality metric for endoscopists.
Exactly. Because SSLs were being missed, the concept of the sessile serrated lesion detection rate, SSLDR, was introduced, analogous to the adenoma detection rate, ADR. There's now a target benchmark. Endoscopists should be detecting SSLs in at least 6% of their average risk screening colonoscopies. It pushes everyone to look harder for these subtle but important lesions.
Okay, let's talk hereditary syndromes. Familial adenomatous polyposis, FAP. That's the one with hundreds or thousands of polyps.
Yes, FAP is caused by germline mutations in the APC gene. It leads to the carpet-like growth of adenomas throughout the colon, typically starting in adolescence. The risk of developing colorectal cancer is essentially 100% by the mid-40s if the colon isn't removed.
So screening starts super early?
Incredibly early. Flexible sigmoidoscopy or colonoscopy usually begins around age 10 to 12 to establish the diagnosis, and prophylactic colectomy is typically recommended in the late teens or early 20s.
After the colectomy, what's the main long-term cancer risk these patients face?
The biggest concern shifts to the upper GI tract, specifically duodenal cancer, particularly around the ampulla of Vater where the bile and pancreatic ducts enter. Duodenal polyposis is common in FAP.
So they need upper endoscopy surveillance. How is that guided?
Yes, lifelong EGD surveillance is crucial, usually starting around age 25. The frequency of surveillance is determined by the severity of the duodenal polyposis, which is formally staged using the Spiegelman classification.
Tell me more about the Spiegelman score.
It's a scoring system based on findings at EGD. It looks at the number of duodenal polyps, their maximum size, their histology, tubular versus villus, and the degree of dysplasia, low versus high grade. You add up points for each category. Stage 0 is no polyps, while stage V indicates severe polyposis with high-grade dysplasia carrying a high risk of progression to cancer. The stage dictates surveillance intervals, maybe every 5 years for stage A, but annually or even consideration of surgery for stage 4.
Okay, moving to the hematomatous syndromes. Poyst-Jagger syndrome, PJS. What are the key features there?
PJS is caused by mutations in the STK11 gene. The classic features are those characteristic mucocutaneous Biggen spots, small, dark brown or bluish spots around the mouth, nostrils, eyes, and sometimes on the hands and feet, and then GI polyps.
What's special about the PJS polyps?
They are hamartomas, not adenomas. Histologically, the defining feature is arborization, branching bands of smooth muscle extending up through the polyp substance like the branches of a tree. While the polyps themselves have low malignant potential, they can cause bleeding or intussusception. The main cancer risk in PJS is actually increased susceptibility to various other cancers.
Like which ones?
Very high risks of colorectal, stomach, small bowel, pancreatic, lung, breast, ovarian, and testicular cancers. So patients need extensive multi-organ cancer surveillance throughout their lives.
Got it. Now, the most common hereditary syndrome, Lynch syndrome, previously HNPCC.
Lynch syndrome accounts for maybe 2–3% of all colorectal cancers. It's caused by inherited mutations in one of the DNA mismatch repair, MMR genes, most commonly MLH1, MSH2, MSH6, or PMS2. These genes normally fix errors made during DNA replication.
So if they're mutated, errors accumulate.
Exactly. It leads to a state called microsatellite instability, MSI, where DNA errors pile up rapidly, dramatically increasing the risk of certain cancers, especially colorectal cancer.
What are the characteristics of Lynch-associated CRC?
They tend to occur at a much younger age than sporadic CRC. The average age of diagnosis is around 44. They also have a predilection for the right side of the colon, about 70% proximal to the splenic flexure. And importantly, patients with Lynch syndrome are also at high risk for other cancers, particularly endometrial cancer in women, but also ovarian, stomach, small bowel, pancreatic, biliary tract, brain, and urinary tract cancers.
How is Lynch syndrome typically diagnosed now? Is it universal screening?
Yes, the recommendation is for universal screening of all newly diagnosed colorectal cancers for evidence of MMR deficiency. This is usually done on the tumor tissue itself, typically starting with immunohistochemistry. IHC.
IHC looks for the MMR protein.
Right. IHC checks if the four main MMR proteins, MLH1, MSH2, MSH6, PMS2, are present in the tumor cells. If one or more are absent, it suggests MMR deficiency. Alternatively, labs might test the tumor directly for microsatellite instability, MSI high status.
If IHC shows loss of MLH1, there's an extra step involving BRAF testing. Why is that done?
This is a key step to differentiate inherited Lynch syndrome from a common sporadic cause of MLH1 loss. If IHC shows MLH1 is missing, the next test is for a specific mutation in the BRAF gene, P600E, in the tumor.
And what does the BRAF result tell you?
If the BRAF V600E mutation is present, it strongly suggests the MLH1 loss is due to sporadic hypermethylation of the MLH1 gene promoter, a common event in non-hereditary MSI high colon cancers. In this case, Lynch syndrome is effectively ruled out. However, If MLH1 is lost on IHC and the tumor is BRAF negative, then you have a high suspicion for Lynch syndrome, and the patient should be referred for germline genetic testing of the MMR genes.
Makes sense. And if Lynch is confirmed, what's the surveillance?
Intensive colonoscopy surveillance is crucial. It typically starts much younger, around age 20, 25, or 10 years younger than the earliest CRC diagnosis in the family, whichever comes first. And the colonoscopies need to be frequent, usually every 1 to 2 years, because Lynch-related polyps and cancers can develop rapidly. Surveillance for extracolonic cancers, like endometrial screening for women, is also critical.
Okay, let's talk about colorectal cancer trends and polyp management. We mentioned the rising incidence in younger adults.
Yes, it's a worrying trend. While overall CRC rates have been declining, largely due to screening in older adults, the incidence in people under 50 has been steadily increasing since the 1990s. This is a major driver behind the recommendation to lower the screening age.
When we find cancer that's confined to a polyp, a T1 cancer invading the submucosa, can we sometimes just remove the polyp endoscopically, or does the patient always need surgery?
That's a critical management decision. It depends on the assessment of risk for residual cancer or lymph node metastasis after the polypectomy. If the polyp was removed completely, en bloc, with clear margins, and there are no high-risk features on histology, then endoscopic resection alone might be sufficient.
What are those high-risk features that would push towards surgery?
The main ones are poor differentiation of the cancer cells, evidence of lymphovascular invasion, cancer cells seen in small blood vessels or lymphatics within the polyp stalk, invasion deep into the submucosa, usually defined as 1 millimeter or involving the deep margin, or if the polyp was removed piecemeal, making margin assessment unreliable. If any of these are present, the risk of residual cancer or lymph node spread is higher, maybe 10–15% or more, and surgical resection that a bowel segment is generally recommended.
But if it's low risk, good differentiation, no LVI, shallow invasion, clear margins,
then the risk of lymph node metastasis is very low, probably less than 2%. In that situation, especially if the patient is older or has comorbidities, foregoing surgery and opting for intensive endoscopic surveillance is a reasonable option. That surveillance would typically involve a repeat colonoscopy sooner, perhaps at 3 to 6 months, then 1 year, 3 years, and 5 years.
Okay, the main event, colon cancer screening guidelines. Let's hit that age recommendation again.
For average risk individuals, the strong recommendation from the U.S. Preventive Services Task Force, USPSTF, and multiple societies is to start screening at age 45.
And when do you stop?
Screening is generally continued through age 75. For ages 76 to 85, the decision becomes individualized based on the patient's overall health, life expectancy, and their prior screening history. Screening is generally not recommended after age 85.
What about the screening tests themselves? Let's compare the stool-based tests, FIT versus stool DNA.
FAT, the fecal immunochemical test, detects human hemoglobin in the stool. It's specific for human blood, requires annual testing, and is pretty good at detecting cancer, though less sensitive for large polyps. It's cost-effective. Stool DNA tests like Cologuard combine FIT with testing for abnormal DNA markers associated with CRC and polyps shed from the colon lining. It's done every 3 years.
How does Cologuard perform?
It has very high sensitivity for detecting existing colorectal cancer, over 92%. However, its sensitivity for detecting advanced precancerous lesions, the large adenomas or SSLs we want to remove before they become cancer, is significantly lower, only around 42%. And importantly, any positive result on FIT or stool DNA requires a follow-up diagnostic colonoscopy.
Okay, now the new kid on the block, the cell-free DNA blood test, SHIELD. How does that fit in?
This is a blood test that looks for specific signals and DNA fragments circulating in the bloodstream that are shed from colorectal cancer cells. The recent FDA approval was based on the ECLIPSE study.
What did that study show in terms of performance?
It showed good sensitivity for detecting existing colorectal cancer, particularly stage 2 and beyond. The overall CRC sensitivity was around 83%. However, similar to stool DNA, the sensitivity for detecting advanced precancerous lesions was quite low, reported at only 13.2%.
13%. That's really low if the goal is prevention.
Exactly. This firmly positions the current cfDNA blood test as a cancer detection tool, not a cancer prevention tool. It might find cancer that's already developed, but is likely to miss most of the large polyps the colonoscopy aims to remove to prevent cancer in the first place.
So who is this blood test for then?
The current thinking and FDA indication is that it's an option for average risk individuals who refuse or are unable to undergo other recommended screening methods like colonoscopy or stool-based tests. It's seen as better than no screening, but definitely not equivalent to colonoscopy for prevention.
Which brings us right back to colonoscopy quality. If colonoscopy is the gold standard for prevention, what's the most crucial quality metric?
Unquestionably, the adenoma detection rate, or ADR.
Why is ADR so critical?
Because the main reason people develop cancer after a colonoscopy, post-colonoscopy colorectal cancer, or PCCRC, is that polyps were missed during the procedure. The ADR directly measures how good an endoscopist is at finding adenomas during screening colonoscopies. Higher ADR equals fewer missed polyps.
And there's a direct link between ADR and cancer risk.
A very strong link. Landmark studies have shown that for every 1% increase in an individual endoscopist's ADR, their patients experience a 3% decrease in the risk of developing interval colorectal cancer and a 5% decrease in the risk of fatal interval cancer. It's a powerful indicator of protective benefit.
What's the target ADR clinicians should be aiming for now?
The recommended minimum ADR target has been raised. The overall target is now at least 35%. It's often broken down further, aiming for 40% in male patients and 30% in female patients, reflecting baseline differences in polyp prevalence. Meeting these targets is essential for providing high-quality preventative colonoscopy. And remember the SSLDR target of 6% too.
Absolutely. Okay, quick practical point, bowel prep. Still split-dose PEG. Any updates?
Yes, split-dose polyethylene glycol PEG-based preps remain the gold standard for achieving excellent bowel cleansing, which is also crucial for polyp detection. The key is splitting the dose, taking half the volume the evening before and the second half the morning of the procedure, typically finishing about 4 to 6 hours before the scope.
Any flexibility on the diet the day before? Clear liquids can be tough.
There is some welcome new guidance here. For many average-risk patients undergoing screening, allowing a low-residue diet, foods like white bread, pasta, rice, eggs, clear juices, broth, avoiding nuts, seeds, high-fiber vegetables, for breakfast and lunch the day before the procedure, followed by clear liquids in the evening, is now considered acceptable and may improve patient tolerance and adherence compared to a full day of clear liquids only. Always check specific institutional protocols, though.
Good to know. Finally, polyp surveillance. After polyps are removed, how soon does the patient need to come back? What do the 2020 USMSTF guidelines say?
Surveillance intervals are based on the findings at the index colonoscopy specifically, the number, size, and histology of the polyps removed.
Give us some examples. Low risk.
If you find only 1 or 2 small 10mm tubular adenomas with low-grade dysplasia, that's considered low risk. The recommended interval is longer now, 7 to 10 years.
What about higher risk findings?
If you find 3 to 10 adenomas, or any adenoma, 10 millimeters, or any adenoma with villous features or high-grade dysplasia, or a large SSL at 10 millimeter or an SSL with dysplasia, that puts the patient in a higher risk category. The recommended interval is shorter, 3 years.
And for patients with serrated polyposis syndrome?
SPS. SPS, defined by having multiple serrated polyps, carries a high risk of interval cancer. Those patients need much closer surveillance, typically annually. The guidelines provide detailed tables for various scenarios.
We have really covered a vast amount of ground here, from acute infections and C. diff management through chronic diarrhea and constipation workups, IBS mimics, hereditary syndromes like Lynch, and right into the nuances of modern CRC screening and quality.
It's a lot, but hopefully synthesizing it this way helps highlight the key clinical decision points. Things like, not using antibiotics for EHE, the need for that luminal agent in amoebiasis, the importance of biofeedback for dyssynergia, that alexidolin contraindication, and of course the absolute centrality of ADR and now SSLDR in colonoscopy quality.
So here's a final thought to leave you with. We have this new cfDNA blood test, SHIELD, offering unprecedented ease and non-invasiveness for screening. It's a major technological step. But we also know that high-quality colonoscopy, by finding and removing polyps, is still the only method that truly prevents cancer rather than just detecting it early.
Right. Detection versus prevention again.
So the question for the future is, how do we as a healthcare system, and how do you in your practice balance these options? How do we effectively communicate the trade-off so patients can choose the screening strategy, easy detection, or more invasive prevention that truly aligns with their individual risk, values, and goals? That conversation is going to be critical in the years ahead.
It really is. It's a communication challenge we all need to be ready for.
Yeah.
Thank you for joining us for this deep dive.